patient's BMI, weight and height you have to check, sir. And then with that we can do the...
How you calculate the BMI?
So weight in kg by height in meter squares.
The normal BMI.
So normal is 18 to 25.
So she said she will look into the nourishment. There are two methods for looking into the nourishment. One is the body mass index. Number two is the mid-arm circumference. So both you can take and you can say the patient is. Can you hear me? So that is a number one. Before that, she presented like the patient presented with cough, breathlessness, and hemoptysis. Can you use hemoptysis as the presenting symptom? What is hemoptysis? Blood in sputum. Is it correct? Hemoptysis is defined as the coughing out or expectation of blood from the lower respiratory tract. So I can cough out blood like it is not hemoptysis. So always use patient own words. If I ask the patient, do you have hemoptysis, he may not understand. So use the patient words as much as possible in the presenting complaints. Never use medical jargons like no hemoptysis in the presenting complaint. Use coughing out of blood. So unless you document that the blood is coming from the lower respiratory tract, hemoptysis rate is not correct. It's not a grave mistake, but as far as possible, as an undergraduate, you just say cough, chest pain, breathlessness. Don't use dyspnea. No, breathlessness, blood in sputum, and what are the other respiratory symptoms where you decide? In your examination, you will be given a case now. You have to decide which system is to be examined based on the symptoms. As sir pointed out, cough is the cardinal respiratory symptom, then comes breathlessness, then comes chest pain, then blood in sputum, fever. That is part of breathlessness. What is the difference between breathlessness and wheeze? Wheeze is actually audible. Even without a stethoscope, you can like that. You can hear it from. That's actually the difference between wheeze and rhonchi or breathlessness. Okay. So the other symptoms where the respiratory system could be involved are loss of weight, loss of appetite, and hoarseness of voice, etc. So the main complaints are cough, breathlessness, chest pain, fever, and blood in sputum. If any one or more than one complaint is there, we decide that the patient respiratory system is to be examined. Sir has rightly pointed out, lungs and respiratory system and heart are jointly working. Any patient with like breathlessness or chest pain, you need to look into the cardiovascular system also. But the first examination will be on the respiratory system, then just go and take a quick examination of the cardiovascular. Unless you also take the FX for any markers, etc. Now after that we will go into the examination. The first point you need to do for demonstration is the patient nourishment. Either you can use the BMI or the mid-arm circumference. Go ahead.
Then comes pallor, interest, cyanosis, clubbing and lymphadenopathy, sir. Pallor is...
What is the best position for examining a respiratory system patient? Patient will be. So before starting the clinical examination, I would give one point or clue. For any physical finding, if the examiner asks you to demonstrate for the exam, but during your practice you may just look like that. No, when you are asked to demonstrate a finding, first you will think what is the position of the patient. No, this is very important, especially during percussion. Never ever do percussion in the lie down position. No, that will come later on. So any physical finding, first you just think what is the position of the patient. For respiratory system examination, you look at a free movement of the respiratory system. No, anteriorly, laterally, posteriorly. If I lie down here, the posterior part of the respiratory system will not move. So allow a free movement. So for respiratory system examination, if possible, if a patient is healthy enough, the best method is to sit on a stool or a bed or a chair, allowing all the sides, anteriorly, posteriorly, laterally to move. So that is the position of the patient for respiratory examination preferably. Number one. Number two, you do the procedure which is described in Hutchison or a standard test group. Number 2. Number 3, you interpret your finding, like clubbing is present or not, or like that. That is your finding. Number 3, what is the clinical relevance or significance of that finding? Okay. So these 4 points you have to remember. That before, suppose the example, do the what you call anemia or clubbing, whatever it is. What is the position of the patient? What is the method you are doing, whether it is correct or that's what we are going to demonstrate. Number 3, what is your finding? Number 4, what is the clinical significance? Okay, this may not be very important for a anemia examination. Even if you do the diagnosis, it's okay. But just keep in mind that before going to the demonstration. Okay.
So patient in the sitting position or?
He is comfortable now. We can see.
So as seen in the lower palpebral conjunctiva, we have to ask the patient to look at so palpebral not absent, so it is no palpebral.
It's not present.
Not present, sir. Then iris is seen, sir, which is.
What else you look for when you are looking into the eye?
We have to see any congestion or chemosis, any harness or ptosis is present, partial ptosis, and then.
Vein congestion?
So in superior vena canal obstruction, we can see chemosis and congestion.
Another common thing, most common thing is COPD where you will have polycythemia. So you have to see in both eyes usually, because in those days they used to exist. One eye you should not look for pallor or polycythemia in one eye because the person may have conjunctivitis. So in that eye if you see anemia will not be identified. So always you should see in both eyes.
And then ictus is seen in the bulbar. It is absent, sir. Then cyanosis is seen.
For what cycles you are looking into the mouth? This part?
Peripheral sinus. Sir, and then we
You
have
need to look in the lower lip.
differential.
Anybody? What is differential cyanosis?
Differential cyanosis. One person can answer.
In PDA, sir, we have lower limb cyanosis.
What is differential cyanosis? First you say that. Not the etiology.
It's not in the upper limb only. In the lower limb, any one of the limbs will have cyanosis.
Usually there is a general condition like it has to be present in all the upper limbs and four lower limbs. So you may see only the lower limbs, not commonly the upper limbs. Vice versa also you can say that. Differential clubbing. The patient has upper limb clubbing.
Yes, upper limb clubbing along with the lower limb normal can happen in transposition of great vessels. That is very, very rare, but the upper limb clubbing along with the lower limb will be normal. The differential clubbing and cyanosis will happen in which condition? One more thing we used to say differential clubbing is infected abdominal aorta aneurysm that you will have lower limb clubbing also.
Okay, there are two conditions. One is PD reversal effect. Number 2, if you have an aneurysm in the abdominal aorta, if you have placed like a infect, if that where the forces which you have kept for treatment, if you get secondary infect, then also you have a lower limb clubbing alone. Can you get upper limb clubbing alone? The above two conditions produce lower limb clubbing and upper limb is free. Can you guess any condition where the upper limb there is clubbing?
Pancreas tumor.
Pancreas tumor, okay, not very common.
Sarcoidosis.
Sarcoidosis will produce pan-digital clubbing. That also produces all limbs. If you have innominate artery or subclavian artery aneurysms, you can get even unilateral clubbing or upper limb clubbing. Okay.
and then we'll see for clubbing.
So the take-home point is
So clubbing, we'll ask the patient to let them taste.
you have to look the upper lips and lower lips before saying there is clubbing present or not. Okay.
Clubbing is first seen, we have to compare it with our own fingers, sir, and then we have to ask the patient to do Shamrock sign and fluctuation test, sir.
So before demonstrating, if I ask what is clubbing, bulbous enlargement, that is a Harrison definition, but the respiratory books are not agree with that. Bulbous means it's actually a grade 3 sort of clubbing, no? So normally you have an angle in it. What is that angle called? Or hyponychial angle. When that angle obliterate, you can call it as clubbing. So clubbing is given as the obliteration of the or hyponychial angle. So that is actually grade 1 clubbing. What is grade 2? Grade 2. When there is fluctuation, it is grade 1. When the angle is obliterated, it is grade 2. When there is parent or transition, it is grade 3. And what is grade 4? So if there is a patient with grade 1 clubbing, how will you look for?
We should fix the thumb under the pulp of the finger, and we should with index finger we should fix the interphalangeal joint, and we should fluctuate and feel for any fluctuation on the other side.
Did you understand that? Can you just demonstrate once again?
Pulp of the finger, we should with thumb we should.
Preferably you take the non-dominant hand. This hand you may be using very frequently, so you preferably take a non-dominant hand because there are a lot of trauma you can have. A non-dominant hand, then
We should face the thumb, our thumb, and
either you can use the index finger or middle finger or the ring finger. Anyone is okay.
then we should fix the interphalangeal joint, and movement should be given on one side, and we should feel the fluctuation on the other finger.
So you have to fix the interphalangeal joint. Either you can fix like this, or you can use your thumb down and use these two fingers and press one here so that how much the other one is elevating. You can support like this and keep it like this. So you press it and see how much the other one is elevating. That is the. So normally the elevation won't be there much, but if there is an undue elevation, you can see there is increased the position of soft tissues, connective tissue, and it is grade 1 clubbing. How will you do the grade 2 clubbing? How will you do that?
இப்படி செய்யணும்.
So she was demonstrating the grade 2 clubbing. What is grade 2? Obliteration of the contact. Either you can use like this. Can you see a diamond shaped space there? Or the best method is you can ask the patient to fold all the fingers and you can use like this or like this also. You can use. This is a correct method. Normally you see a diamond shaped space there. If it is obliterating, there is grade 2 clubbing. Grade 2 clubbing. Okay. What is grade 3? Just an observation of whether it is drumstick or parallel. And how will you look for the grade 4 clubbing hypertrophic pulmonary osteoarthropathy? Hypertrophic pulmonary osteoarthropathy has 3 components. Number 1 is clubbing. Naturally the patient will be having grade 3 clubbing. Then how do you look for hypertrophic osteoarthropathy? Then you ask the patient whether you have pain in the joints, or you can ask the patient to do like this and ask for any pain in the joints. Number 3, you can just palpate the long bones and see for the subperiosteal new bone formation, which is very difficult to interpret clinically. But if the examiner asks you, you can just do a palpation or a flowing movement like this on the long bones. But it's very difficult to do it. So you look for clubbing and pain in the joints or arthralgia. Then the third component is some examiners will ask how will you confirm hypertrophic pulmonary osteopathy. What is the confirmatory test? Radiological test like a X-ray. Again difficult to see a subperiosteal movement formation. A technician bone scan or a bone scan is the gold standard for hypertrophic pulmonary osteopathy. So what is the respiratory condition which produces clubbing? Access has to come from there also. Suppurative lung disease. Bronchogenic carcinoma. Cystic fibrosis. How many cases of cystic fibrosis you have seen? I have seen only one case in my life. But you can add that also. The common condition which you see, you can remember three diseases. Number one is carcinoma lung. Number two is suppurative lung disease. Number three, interstitial lung disease. Very common three conditions which produces. Even tuberculosis you may see, but these three conditions don't forget. Can you repeat? Sub-question. Which carcinoma lung is most common to produce clubbing? Small cell carcinoma. Which interstitial lung disease is most common to produce? Idiopathic pulmonary fibrosis. Have you ever heard that terminology? Yes. Which suppurative lung disease is most common to produce clubbing? Even the all, it is bronchiectasis. Bronchiectasis, but lung abscess and emphysema. These are the three conditions which comes under. All the three produce, but the prevalence wise the most common is bronchiectasis. But lung abscess also, it's very common to see clubbing. Okay. So how will you look for clubbing in clinical examination? Just see the patient's hands and lower limbs. If it is obvious clubbing, there is no need of doing all this. If there is a confusion, do the Shamrock sign or the fluctuation. Okay. So obviously clubbing. Look at the upper limits and lower limb. You just say clubbing is present. If it is drumstick or canopy, grade 3. If there is a doubt, do the Shamrock sign. Still it is absent, do the fluctuation. Actually it should be assuming the reverse order. Okay. And if there is grade 3 clubbing, you ask the patient whether you have joints in there, pain in the joints, and there is hypertrophic osteopathy, and these are the conditions which produce. Okay. We have only 1 hour, sir. We have only 1 hour.
1 hour. 10:30.
So I think the important findings which are commonly asked for examination, demonstration, we will concentrate. Others we will skip that.
Up to 10:40.
Shamrock sign, I think the examiners will ask. Demonstrate Shamrock sign. And the other signs we will go. Okay.
So and then lymphadenopathy we have to see cervical, scaling, cervical lymph node, scaling lymph node, and supraclavicular lymph node and axillary lymph node. So
Just demonstrate how you look for the how you look for the cervical lymph node.
so from the back.
So that's very important. Now some examiners, like senior examiners, are looking whether you are just doing the method correctly. No, you have to on the back of the patient to look for the cervical lymphadenopathy, which is a common group of lymph nodes enlarged in respiratory system enlarged examination.
Submental, submandibular, and then all the
What will you specifically look for when you are examining to look for the etiology in a lymph node?
So any signs?
Right, very good.
Consistency.
Consistency of
And as in which, what will you derive consistency?
mated lymph nodes can be seen in
Lymph node in case of tuberculosis. That is, it is because of the adenitis, periadenitis, which causes mapping of the node.
and then
Firm and malignancy.
Fairly hard in my
Rubbery consistency.
Rubbery in case of
So you look for single node or multiple nodes. If multiple nodes, you look for whether there is a matching or not. And matting indicate, multiple matting nodes indicate the possibility of tuberculosis. Single node, usually hard, indicates malignancy. A firm or a shorty node indicates lymphoma. Okay.
And then we are coming to the systemic examination. For first, we should see the head to toe.
See this patient, isn't it? You have to examine this patient, general examination over. Have you missed anything? Anybody? அதெல்லாம் விட்டுட்டா இங்க ராவலிய சொல்லி இருக்குது நானே சொல்லுங்க when though it may not be significant but thing is you have to see the person as a whole that you should want to do we may not throw any light on it but you have any abnormal finding you have to tell them because examiner will insist on that any hypopigmented patches to look for Hansen disease all these things you have to look for head to foot examination is important at a glance you can see it is striking at your eyes probably on the kadaisi open then you can anyway there is something that you should do because that shows you have examined the patient properly there is no clue for it.
And then we are going for the vitals. We should check the pulse rate, respiratory rate, and BP, temperature, and JVP. And we are going for the systemic examination.
What is the significance of pulse in respiratory disease? Pulse rate. Tachycardia. Is there anything else?
Pulses.
Pulsus paradox is recorded in the BP. It's not the palpable. The only important thing you should look for is atrial fibrillation. Atrial fibrillation is common in pneumonia because they say pneumonia if it is involves myocardium it can cause atrial fibrillation. So in a respiratory disease we insist on that. Other thing is tachycardia. That in all situations where you will have a tachycardia. Bounding pulse, COPD. When there is a CO2 retention, will cause vasodilatation. So you will have a bounding pulse. The other important thing where you will have a bounding pulse, other than cardiovascular disease, is cirrhosis liver. When there is a cirrhosis liver, you will have a large volume pulse because estrogen is not degraded. So one of the examiner is insisting that unless you say large volume pulse, you will not allow the the candidate to leave the hall because he was examining the cirrhosis liver. So he was insisting on large volume pulse. That you should remember.
I think pulse, JVP, everything you will be covering in the serious examination also. So the one is important is counting the respiratory rate. How will you do the counting of respiratory rate? And the other thing I think JVP and then we will skip because cardiovascular examination will be anyway we will be discussing and demonstrating. How will you record the respiratory rate?
We should see as if you are seeing the pulse, and one hand should be kept over the abdomen of the patient, and we should
So most
check.
of the respiratory section examination is to be done in sitting position or standing if the patient is healthy enough. But the preferable position is sitting on a stool. But the one which you can do in the lying down position, one finding is respiratory rate. The patient can lie down comfortably on the bed, and you have to keep your right hand on the abdomen, and you just count the number of the movements as if you are just observing his face and all. No, he will not. So otherwise he will be anxious or respiratively. You can keep your hand on the abdomen, and as if you are counting the pulse rate or something like that, you can look into the movements. That is the best method for respiratory rate. Okay.
And then we should
What is
see.
the respiratory rate? Company.
You can tell. No, yes.
And the respiratory rate is very low. That is bradypnea. When will you say bradypnea? Less than 8. Where will you have bradypnea? Hypothyroid and any sedative or narcotics can cause bradypnea.
What is the normal respiratory rate? 12 or 14 to 18 in adults above the age of 8. Between 1 and 8 it will be 20 to 30. Below 1 year it will be 30 to 50. So that's the respiratory rate. If the patient is rate will be around 14 to 18, no? 12 to 18, that's the average rate. How much it is? Suppose it is 20, what is it? It's more than 18, huh? Okay, so
Tachypnea or maybe patient is
it's a
nervous.
tachypnea, patient has increased respiratory rate. There are different terminology related to respiratory rate. One is the normal respiratory, which is 12 to 18. If it is more than 80, it's okay. More than 20, 22, 24, then we call it as a patient is tachypnea. So what is tachypnea?
Increase
Only increase the
respiratory
respiratory rate. Okay. What is hyperpnea?
increase in depth of the respiration
What is hyperventilation?
rate and depth of
Increase in the actually the minute volume. The rate and the depth according to the physiological or metabolic demand. When I start work, the rate will increase accordingly. Okay. There can be voluntary hyperventilation, but that is actually the difference between tachypnea and hyperventilation. Okay. Other terminologies are as discussed, like orthopnea, vasoconstrictor dyspnea. Then what is bendopnea? Have you heard of a term called bendopnea? The patient will have more breathless when he bend forward. When he lie down on one lateral position, that's called hypopnea. Have you heard a terminology called platypnea?
sitting position.
Patient will be comfortable, lying down position, and he will feel breathless when he sits or stand up. If you ask the patient sit up, he will not. That is platypnea. Any respiratory condition which produces hepatopulmonary syndrome.
And we should see for head-to-toe examination. We'll start from the eye. We should see for any partial ptosis and which is seen in Harness syndrome and congestions and endocytic test and all. And then we'll go for the external we should see for any halitosis, presence of halitosis. It is seen in suppurative lung and we should see for astrixis. Astrixis is seen in CO2 retention and for any gynecomastia and small muscle wasting, and we should see for any external markers of TB and cor pulmonale, and we'll go for the examination. First we should start with the
So head-to-foot examination is actually common for all systems, no? General examination. Now we'll concentrate on the respiratory system examination today now. The other is actually common for all systems.
we'll start with the oral upper respiratory
Upper
tract
respiratory examination.
inspection.
What about the nose?
What you are looking? You look for the oral hygiene.
Oral hygiene, dental caries,
Ask the patient to open the mouth. Look for the oral hygiene, dental hygiene,
and
oral brush.
and for any
Caries
tar
too.
staining, tonsils.
Nonsense. Okay. So when you are looking for the oral hygiene and caries tooth, everything for the respiratory system Sarah has pointed out now. There is predisposing factor for pneumonia is for actually one airway, one disease, no? So actually one airway and one disease. Anything in the upper respiratory or upper airway will go into the lower respiratory also. A bad oral hygiene, caries tooth, and everything can cause predispose for a lower respiratory infection, including lung cancer, pneumonia, etc.
And then we'll go for the nose. In nose, we'll see for any nasal septal deviation or polyp. And then we'll come in for the inspection.
If you see polyp, what is the respiratory system relevance?
Asthma.
In allergic asthma, you can have anthracoinal or polyp, usually bilateral. Certain autoimmune conditions. The common one is asthma, then cystic fibrosis you can have. There are other conditions also, I think the more arterial that's not required. Okay, you look for the polyp, continue.
And then we should look for the inspection, we should stand in the
So now method of looking for the movements in inspection.
After inspection, we go into palpations.
What about trachea?
we should see for the
Yeah, you are not just recollecting, no? You have so in inspection, what are the things you will complete that? Inspection, what are the things you look?
trachea, chest shape,
Of chest,
movement of chest wall,
of the chest,
deformity for any chest deformity, trachea, apex beat,
yeah.
and for any spinal
Any
deformity,
scars or any sinuses or scars,
dilated veins,
any
discharging sinus or dilated
swelling
veins,
scars and any swelling scars and then
for any drooping of shoulder, and hollowness in the supraclavicular and infraclavicular area, and spine deformity, kyphosis and scoliosis.
position of the trachea, position of the apex beat, any other abdominal pulsation, all these are to be included in the
Inspection.
One more thing we have to look for is vinyasa.
So now the two important things in the inspection. The rest you can read. Demonstration of trachea and demonstration of drooping of shoulder. These things are very important, commonly asked for examination. Now we will consider how you do for a trachea inspection. Then we will complete the palpation. So for position of the trachea in inspection, the position of the patient has to be sitting. Never do the tracheal position, the lying down position. So the patient is sitting comfortably on the bed. Okay, then
Patient to look straight, and we should see for any sternocleidomastoitis with prominence in the clavicular head, and we should ask the patient to
so tracheal position of the trachea, which is very important in the respiratory system, to be confirmed later by palpation. Inspection, the patient has to be comfortably sitting on a stool, and he should not shrug the shoulders. The head has to be like this, and you see how the trachea is it central or shifted to one side. To confirm that, you can look for the clavicular head of the sternocleidomastoid. Clavicular, this sternocleidomastoid has clavicular head and sternal head. You look, concentrate on the clavicular head of the sternocleidomastoid. This is the left one, this is the right one. If one clavicular head is more prominent, you can say that trachea is possibly shifted to that side. That side is called right side. What is right side?
So, shifting of due to the shifting of trachea, there will be prominence of the
Right side, just say an undue prominence of the
clavicular
head of the
sternocleidomastoid.
sternocleidomastoid. It indicate there is a possibility of trachea shift to the
Same side.
side or same side. What is the mechanism of right side? Any student?
Sternocleidomastoid is covered with pretracheal fascia, and the trachea is possibly shifted to that side. There will be relaxation of the pretracheal fascia, so that the sternocleidomastoid is more prominent in the side.
Very good. The trachea and sternocleidomastoid are lined with the same deep cervical fascia, and they are in an elastic tension. When the trachea shifts, there is a relaxation happening, and the both clavicular and sternal head will come forward. But the more coming will be because it is closer to the trachea, it will come over. So that is the inspection by tracheal position by inspection. Now, can you do the drooping of shoulder or linear scapula in inspection? So that is actually can be done in the both inspection and palpation, but we will include the inspection. How will you look for the drooping of shoulder or bringing of the scapula?
So, drooping of shoulder stand behind the patient and then.
So remember, in that finding, the patient position has to be standing. He has to stand. Certain examination will be you are just looking whether you are asking the patient to stand. So the position of the patient has to be standing. Now we are demonstrating the grouping of shoulder in inspection. In inspection. For that, the patient has to stand. Then
So we have to view from the back of the patient. To view from the back.
the patient has to be like this. You should not cut the hands. Where you have to stand?
To stand behind the patient and we have to
Yes. The examining person has to be at least distance of 4 to 5 feet away from the patient. You cannot do like this. You cannot do closer. You have to be away from. Right? And look for 3 points. Number 1 is the level of the shoulder. Level of the shoulder. This patient. In the normal question, what will happen? Both the shoulder will be at the same level. Both the scapula, specifically the medial border or the inferior angle of the scapula will be same, and the spino-scapular distance will be equal. This is the one finding where you can touch the patient even in inspection. That's what in the postgraduate teaching. You can even touch or even measure. Otherwise, in inspection, you are not supposed to touch the patient. But this finding, even you can touch the patient. Okay. So here the shoulder level are almost the same. Both scapula are specifically for the inferior angle of scapula. Sometimes there will be confusion. So the most important component of grouping a shoulder is the spino-scapular distance. Okay. Because there are a lot of patients. The best example is Malayalam. There is an actor called Mohanlal. All mimicry artists are mimicking Mohanlal like this. It's a fact that he has a right shoulder very lower level, but he has no grouping. Why? Only his right shoulder is at a lower level. There is no scapular prominence or no spino-scapular distance difference. So to say grouping, 2 out of 3 has to be there. Since Mohanlal has only 1, he has no grouping. But there is a terminology called the pseudo grouping. So Mohanlal has pseudo grouping on the right side. How will you confirm it is true grouping or pseudo grouping?
We ask the patient to walk.
You ask the patient to bend forward for 30 degrees, then the grouping will be correct. Or you can ask the patient to walk on a straight line like this with arms swinging. If it's a pseudo grouping, it will be correct. It will be correct. Okay, so that is the method. So you have to look for 3 points on the back of the patient: level of shoulder, prominence of the scapular border or the inferior angle, and the spino-scapular distance. To measure the spino-scapular distance, you can touch the patient. You can use a thin marker pencil and you can measure. But obviously, most of the things is not required. You will be observing that. And if 2 out of the 3 is present, you can say grouping. If only 1 is present, it's not grouping, it's a pseudo grouping. There, you can ask the patient to bend forward for 30-40 degrees or walking on a straight line, and the level will be corrected. So it's a pseudo grouping. Okay. For if there is a right-sided grouping present in finding, what is the clinical significance? Suppose there is a grouping on right side, what does it indicate? Grouping present. It indicates there is an ipsilateral wadial loss of lung. That's significance. The same side, the lung has reduced in volume. Which wadial loss is there? We will find out in subsequent examination. Can anyone say what are the causes of wadial loss of lung? Fibrosis, collapse, 2 more. Consolidation will preserve lung wall. Fibrosis, collapse. If you remove the lung, what will happen? Will it reduce in volume? Lobectomy or pneumonectomy? 1 more. If you are born with a small lung, hypoplasia. There are only 4 conditions which reduces the lung. The first 2 are very common: fibrosis and collapse, and hypoplasia or lobectomy or pneumonectomy. That we can obviously, there will be a scar in the patient. Okay. So how will you identify if there is a scar in examination on the lateral part of the patient underwent a lobectomy or pneumonectomy? How will you say that the scar is for a lung surgery or a cardiac surgery? In lung surgery, the scar will be posterolateral. Posterolateral, from lateral to posterior. Most of the cardiac surgery, it will be anterolateral. But nowadays they are actually splitting like this, or splitting like this. So, but if there is a scar which are present in older patient, no. If it is anterolateral, it is cardiac. If it is posterolateral, it is lung surgery. Okay. So, that is in inspection. So, grouping the demonstration. Yes.
Ask the patient to call and we'll see anything.
You can ask the patient to yes.
And then,
Palpation.
so palpation, first we'll start with confirming the position of the trachea.
Before that, you are first touching the patient. Palpation, you are just touching. Any local rise of temperature. I am not interested in the temperature here. Respiratory system, what we are interested in is any local rise in the temperature. Generally, there can be fever. In the absence of fever, there can be respiratory condition where there is local rise in the temperature, local tenderness. So, the first thing you look is whether there is a local rise in temperature or tenderness. Which condition you can get a local rise in temperature or tenderness here? What methodology here can use local rise of temperature or tenderness? Empyema can produce local rise of temperature. Any condition produce local tenderness other than empyema? Costochondritis, fracture ribs, or this can produce local tenderness.
Tracheal position.
Now, another finding which usually examiners ask the undergraduates to demonstrate is a tracheal palpation. Now she is going to demonstrate the tracheal palpation. How we do it? Again, the position of the patient has to be sitting or standing, preferably sitting on a stool or a chair. Okay. You always tell the patient that what you are going to do, especially for tracheal palpation and percussion. You tell the patient what you are going to do. No. I think if you split the examination into all three components, one major component is telling the patient what you are going to do. In his sole language, tell that, okay, get your permission to do this and all. No, that's also okay. You did almost correctly. Can you just tell them how you did it? So, position is sitting or standing. Okay.
Sitting or standing position, you have to ask the patient to look straight and fix the head, and then with two fingers, index and ring finger, with the middle finger we have to feel the trachea, and then we'll have to insinuate our fingers in the gaps so as to see if there is any tracheal shift process.
So, things which you are likely to do mistake are, no, it has to be done in sitting position, number one. Number two, for tracheal palpation, always fix the head with your left hand. Either like this or like this. Either you can fix the back of neck or the head. This is the best method. And tilt the head into 30 degree. Place your ring finger or index finger in the sternoclavicular junction. Backward from the cricoid cartilage from the other sample down and see how it is moving. Whether it is moving centrally or to right or left side. To confirm that, you can insinuate your finger between the trachea and the clavicular head of the sternobastard. 1, 2, 3. 3 insinuation is enough on both sides. If the trachea shift to the right side, what will happen? In your palpation, the finger will move towards the right side, and the insinuation will be difficult. There will be less space on the side of tracheal shift. Okay, so that is a method. I think one finding which commonly the examiners ask for demonstration. Imagine there is a patient whose trachea is shifted to the right side. Right side. What is the significance? What is the clinical interpretation?
It may be normal.
Unlike drooping, which always indicates the ipsilateral pathology, trachea shaft indicate either ipsilateral volume loss or contralateral volume increase. Back to our thinking. Volume loss, there are 4 conditions. What are the conditions where you can get volume increase on the opposite which make the trachea to the opposite side? Sir has mentioned pneumothorax, large pleural effusion, large mass lesion, like that, anything which increases the hemithoracic volume, it may not be lung volume. Hemithoracic volume increase on the opposite. That occurs in pneumothorax because the lung is collapsing in pneumothorax, but air is causing hemithoracic volume increase. So, tracheal shift to one side indicate ipsilateral volume loss or contralateral volume increase of the hemithoracic volume. These are the differential diagnoses. And we will confirm the subsequent findings. Okay. Go ahead with your palpation.
After the chest expansion, you have to say.
Then movement.
Anterior chest wall, we have to keep the hand like this, and then so we could see the hand moving up.
What you are doing actually? You are looking at the movements of what? From palpation onwards, we have to surface mark the areas. What is this supraclavicular area? This is infraclavicular. What is infraclavicular? Below the clavicle, everybody know. Below the clavicle, up to the lower border of second rib. The first space and second space will be included in the infraclavicular region. Below the second space is mammary region. Do you have any inframammary? No. Now there is no inframammary. When I was student, there was nipple level is mammary, then inframammary. Now it's only mammary. So anteriorly you have supraclavicular, infraclavicular, and mammary. Axillary you have axillary and infraaxillary region. Where is the landmark? From root of axilla to the fourth rib is axillary, and below that is infraaxillary. The back we have suprascapular, infrascapular and interscapular. Interscapular is orbitally divided into upper, mid and lower. There is no marking, correct marking. You can just say orbitally. So you have to percuss the supraclavicular region, infraclavicular region, mammary region, axilla, infraaxillary area. General rule is the patient has to be sitting on a stool, allowing the respiratory system to move freely. You keep your 4 fingers in the area where you are doing the movements and see how much your finger is separating or how much your finger is elevating. Both are permitted. Okay. Now you demonstrate the movements by palpation in the supraclavicular region. So she is looking for the movements by palpation. Inspection we already did. She wants to know whether this intraclavicular and this infraclavicular areas are moving normally. The lung inside is moving normally or not. That's our aim now. So you have to hold this area like this, and you can either touch like this and see how much this is separate. Like this. Or there is another method. You can hold like this and put like this also. This movements also. But to get the anterior part, infraclavicular, the best method is keep the fingers like this, touch in the mid-sternal line, and ask the patient to take deep breathing. So in respiratory examination, you can always ask the patient to take deep breathing. The cold breathing may not be repeated. So patient can take deep breathing for your demonstration. So same thing. Sometimes what will happen, the patient is very thick. You may not be able to hold and touch these fingers. You have to draw like that. Will be difficult if the patient is chubby. So what you have to do is, you can just hold it with a marker, skin marker. Have you ever seen a skin marker pencil?
Yes.
You can mark and that distance you can just count. If you can touch these two, it's very good. But the patient is very bulky enough, may not be. So that is the method. The area which you want to do the movements, keep these 4 fingers on that area and look at the separation of these movements which is equal on both sides. That is a simple method of doing the movements by collaboration. Okay. Then chest expansion. Again for chest expansion, you will look for the total chest expansion and the differential chest expansion of the right side and left side. First, she is going to demonstrate how we look for the total chest expansion. Again, the position of the patient is sitting or standing. As the tilers are taking your chest measurement, the preferable position is standing or sitting. Okay. So what she will do?
It is at the level of nipple, and the females it is below the level of breast.
Males at the level of nipple and females just below the nipple. Okay. So she almost did it correctly. What you will do is the patient has to be standing or sitting. For total chest expansion, this tape has 0, 1, 2, 3 up to 150 now. This 0 has to come in the mid-sternal point. 0. Oh, this mathematical line 0 has to come in the mid-sternal point. Wrap it around the nipple. And touch like this. Ask the patient to exhale completely. Then see the initial value. Okay. Then ask the patient to take a deep inspiration and hold it. Then see the second number. For example, if the first one is 120 after exhalation, ask the patient to take a deep inspiration. If it is 126, 6 centimeters of chest expansion. So the things which you can go wrong is take the metal 0 in the mid sternal line, wrap it around the nipple if it is male, below the nipple female, and cross over and see the initial reading after exhalation. Exhalation. Then you see that. Then take a deep breath, and that is total chest expansion. Total expansion. What is normal expansion? 4 to 6, 4 to 7. This is the military, reading. 4 to 6 is the normal. Wow. Can you get more than normal? PT Usha has 7.1. Is it normal or abnormal? She has a respiratory disease. She is an athlete. So there is no upper limit actually. It doesn't mean that it will go below 10 and all. No respiratory disease which will increase the chest expansion. All respiratory diseases will decrease. So even though the average is 4 to 6 or 5 to 7 like that, below 2.5 or 1 inch is always abnormal. Even though 4 to 7, 3 can be normal if other findings are not there. Okay, but below 3 or below 2.5 is always abnormal. Okay. How will you look for the differential expansion of the right and left? You have to go faster.
Patient will be there. When they present the adoptatory lesion, then we can do sedation.
I think up to palpation, then functional observations automatically will come. So the thing which can go wrong is when you do the differential expansion, the right and left belly thorax, this metal part containing 0 will go to the mid-spinal line. Why mid-spinal line? The most fixed point in our body is spine, not the sternum. So this has to be on the back in differential expansion. If I am the examiner, I will be just looking whether you are placing it here or here. Then the finding is wrong now. So that's the concept of Boski. Each step is to be observed. So this will go to the spine, mid-spinal line, wrap it around, repeat the same process. Ask the patient to exhale, take the initial value, take a deep inhalation, and normally it has to be equal. If it is total 4, 2, 2. Suppose there is a patient with a total 4 cm, right side 1 and left side 3. What does it indicate? The lesser side is pathology. The lesser side is pathology. There you can get two information. Suppose there is total 4, right is 1 and left is 3, right is pathology. Okay. Sometimes what will happen? The total will be for example 150. The right it has to be 75. Sometimes what will happen? One side will be 90, the right other side will be 60. So what does it indicate? There are conditions, so this is which can increase the thorax volume. There are conditions which can shrink the hemithorax also. That's also an information for your diagnosis. Always coordinate with the other findings. Okay, so that is it. So that can be palpation or anything else. AP transverse diameter. How will you do that?
Better to have a pad in the area. Person can hold the pad.
It's actually not the correct method. Either you can take two hardboard or two hoop, long hoop, and you can do the anteroposterior lateral. Then probably assistant who is there. If you are using two hooks, the patient can hold like this and you can take the transverse. For AP, you have to keep it like this. That's easy thing.
Same patient with percussion oscillation when they are performing.
Yes.
Anything about the vibration to be done?
The same case they are going to discuss.
So again,